Good afternoon, everybody. My name is Garrett Schmidt. I am the managing editor for ACO Exhibit Hall, and I'd like to welcome you all to today's webinar hosted by Mozzaz, and it is called Leveraging AI-Enabled Remote Patient Monitoring for Preventative Care in the Fight Against Diabetes. And this is a very important topic, managing diabetes in the populations that's so prevalent. So really looking forward to this talk and hearing what these guys have to say. A few items of note before we begin here. All attendees have joined the webinar today in listen-only mode. So if you're listening, you don't have to worry about muting your mic. That's been done for you. Also, the webinar is being recorded, so if you would like to watch it again after the fact or share it with colleagues or friends, you'll certainly be able to do that. So what I'm going to do is after the webinar is concluded, I'm going to be sending over via email to each of the registrants a link to the recording, as well as to a place where you can download the slides. And so you'll be able to do that. And then finally, during the webinar, we definitely want to hear from you. So please submit your questions. You don't have to wait for the Q&A. You can submit them at any time using the control module that you have. There's a little questions area, so you want to put it there. There's a chat too, but use the questions thing, and that way it'll get to the right place. And we're going to get to as many of those as we possibly can during the allotted time. If we are not able to get to yours, we'll make sure to follow up via email afterwards. So again, please ask your questions if you got them, and then we'll get to all of them that come in. So without further ado, at this time, I would like to introduce our speakers, Mr. Rob Petrov and Kevin Mcqueen, both are VP of Business Development with Mozzaz. And also Keely Choel from the Mozzaz team will be joining us to facilitate the Q&A at that time. So I believe Rob is going to kick us off. So welcome, Rob.
Well, thank you, Garrett. And on behalf of the Mozzaz Corporation, I wanted to thank you all for attending this presentation today to hear a little bit more about how you can leverage artificial intelligence, AI, today, specifically with your remote patient monitoring program. You'll see how this can make a direct positive impact to not only your patients' lives, but also a positive return on your bottom lines. So remote patient monitoring can be used across a variety of chronic disease states, individual care plans, or overall care maintenance of your patients. But today we're going to focus on a definitive need in one disease state, diabetes, and specifically the pre-diabetic populations. On the Mozzaz team today, as Garrett said, we have Kevin Mcqueen. Kevin has over 30 years of professional service experience with 10 years specifically in artificial intelligence. And you have myself, Rob Petrov. I have over 20 years of experience in the healthcare industry, ranging from capital equipment, imaging, to lab testing, and of course, IT. Just to make sure we're grounded, we put together a brief agenda that we're going to be following today. First off, diabetes by the numbers. This will clearly illustrate the dilemma that we're facing today as an industry, not only from an individual health perspective, but also the burden that the healthcare system is facing with it. Then we're going to have Kevin describe a little bit more about what AI-enabled remote patient monitoring is, how to kind of design a successful solution, and then kind of what best fits your needs and whether you're a health system, a provider, or even a payer. We'll share some outcomes, as well as we'll talk a lot more about the financial savings impact and how this can really help your institution across on the bottom line. And then finally, as Garrett mentioned, we're going to open up the conversation to everybody to ask any questions or request more information or details about any specific points we made today. So ADA, I'm sure everybody's familiar with it, but these are some statistics from the ADA to show why we're really focusing on diabetes today. The first one's pretty staggering in my opinion. Approximately 1/3 of the United States population is pre-diabetic. So that's around 88 million individuals. The way they define pre-diabetic means that your blood sugar is higher than normal, but not high enough to be considered type 2 diabetes. However, without any lifestyle changes or interventions, these individuals are most likely to develop type 2 diabetes at some point in their life. And according to the ADA, half of that population, so 44 million individuals, are even unaware that they have this problem, this silent problem within their body, which is going to have a lot of impact in their future life and their future health. So Currently, around 11% of the entire pre-diabetic population develops type 2 diabetes each and every year. So 11% of the 88 million. That number, as you can guess, is just going to grow exponentially and compound on itself and really cause major strain on an already strained health system that we have today. As you probably know, type 2 diabetes is a long-term problem. It causes a lot of damage to the bodies of the patients, especially to their hearts, their blood vessels, their kidneys, ultimately driving up their costs and reducing their overall life expectancy. You can see on the far right there, this is a staggering number. The average additional annual healthcare cost per person with diabetes is an additional $16,752. So that includes direct and indirect costs of this disease. However, even if you just look at the direct costs, it's still a staggering $9,600 per individual per year. This is the cost. And in 2017, at the very bottom, you'll see there, they did a study, and they found out in 2017 fiscal year that the cost of diagnosed diabetes alone cost our industry $327 billion, which is crazy. The good news is that the progression of this disease is not inevitable. But how do you get the intervention? How do you get that information out to the individuals that are at risk? First off, you got to find the right patient to help them to prevent any future harm. And this could really only be done effectively and efficiently utilizing artificial intelligence and remote patient monitoring. So what I'm going to do now is I'm going to let Kevin pick it up from here. And as we progress, keep in mind that this could be outside of diabetes, but we're going to focus on that. So Kevin, all yours.
Thanks, Rob. So first we'll begin with some definitions to frame in the vernacular going forward, and then we'll get more into what the solution looks like. So from a remote patient monitoring versus remote patient management standpoint, you all know monitoring is basically connecting device. It's monitoring for a particular clinical disease. That data is collected, monitored, and then acted upon. Typically, it's going to be disparate. It may be plugged into the EHR, although likely not, because it creates such a large amount of data unless it's, a clinical red flag is met. Versus remote patient management, where it is circular in nature with how the data is collected. Remote patient monitoring is just one component of remote patient management. Remote patient management, including virtual care technology, so that the patient and the provider are connected together and collaborate with each other, and the data is circular and dynamic. Continuing with some definitions, so prescriptive analytics and AI engine, right? So an AI engine is basically a massive database. It's a lot of data elements. You can see for our particular solution with Mozzaz, we've got about 4,500 data elements as a part of our core AI engine. And then that's married with claims data, enrollment care management data. So specific patient or population type data that creates an instance of the data or the engine for a provider. That data then has an algorithm written against it to look for patterns, pattern recognition, and correlation, right? So in the simplest form, that is an AI engine. Now, that said, when you talk about prescriptive analytics versus predictive analytics, prescriptive is a little different, and we think the next gen of predictive analytics in that prescriptive is first going to stratify a cohort. So in this particular case, we're talking about pre-diabetes. So it's going to look at a population, it's going to identify the pre-diabetic population, and then it's going to create a custom care plan for the patient. So going from population to patient with a prescriptive care plan for an individual patient. So with those definitions in mind, what is AI-enabled remote patient management, right? So basically it's the two buckets that we kind of just talked about. You've got prescriptive analytics and you have remote patient management. And when you pair those two together, what you have is the ability to customize a care plan from the population down to the patient for a specific, from a specific cohort down to the patient level, right? So we talked about the risk stratification of the cohort. And then the individual consideration for the patient during their entire care journey, so that the care plan is a dynamic feedback loop that can be adjusted as needed. And one example of that is when you take not just claims data, but you actually include SDOH for a patient, specifically when we're talking about prediabetes. If you consider two people with diabetes, one comes from an economically challenged area, one comes from an affluent area, the problems that they have with their diabetes will be very different, and thus the care plan should be different. So a couple of examples of that might be in the economically challenged diabetic area, there's a food desert and it's not safe at night to walk, so exercise is a challenge. And then possibly education, lack of dietetic education, versus in the affluent area, the person maybe eats too many rich foods. So just an example of how SDOH can impact care plan at the specific patient level. And then when you look and think about remote patient management, as we described in the definition a couple slides ago, right, it's going to include not only remote patient monitoring as a device, just as a means to collect clinical data, but then very importantly, the virtual care technology, which is going to allow for collaboration between the patient and the care team and allow for adjustments. And the data and that collaboration can be on a daily or a weekly basis, as opposed to a quarterly visit when the patient comes in to see their doctor and the doctor repeats that you need to exercise more and you need to cut down your sugar, your A1C has been high, right? So it's more of a ongoing real-time collaboration between the provider and the patient. Now, why this is important to all you in ACOs, it's obvious. You want to lower the overall healthcare cost. You want to be preventative with the health problems, right? And you're going to improve care coordination by having basically having the patient and the care team tethered together. So we talked about prescriptive going from population to patient, right? This is just an example of that. So we're going to basically we can take a population and drill down so that the spend that you have to help the most impacted is identified with the artificial intelligence, right? And that's going to happen by vulnerability categories and scoring and percentiles and whatnot. But basically, it's going to get down to top 5 drivers that identify a specific segment of the cohort, so you know who you can help first, right? This is a great way to test with our customers with a pilot, right? We'll get down to a number of a cohort. That's going to be the starting point as a proof point, and then moving forward. So when you're looking at building a solution, it basically falls into 3 buckets we've just talked about. You got the identification, you got the assessment, and you got the intervention. So the identification is the stratification of the cohort using the AI engine, right? The assessment is breaking down to the patient level, looking at them from an individual standpoint and determining what the care plan might be. And then intervention is the virtual care technology that allows for that continuous collaboration between the patient and the care team. So if we break down identification a little bit further, right, we're at the population level. Some of the attributes you can see, they're looking at clinical factors, socioeconomic factors. Again, socioeconomic factors we believe are a very important component of prescriptive versus predictive, because it's going to take a very individual look at the patient, and if the SDOH factors aren't looked at, then the care plan is probably not going to be accurate if you're just looking at clinical data. So some of the key indicators you can see as examples: high obesity rates, low income leading to, reduces to less healthy foods, maybe a food desert, and then education levels as to a healthy diet, what it looks like. So how does your blood sugar go high? What type of foods cause that? What is glycemic index when you talk about foods? Those are the kind of attributes that we're going to drill down to with prescriptive analytics. The heat map up at the top right, basically just showing Population health directors really like this. So you can see from not a predictive, but a pattern recognition standpoint, geospatial correlations for an area that just might not have occurred to you. So getting into the individual, right? We said population to patient assessment is at the patient level, and you're looking at some risk factor attributes for the individual. They're overweight, low health literacy, so back to the diet knowledge, high stress job, and a history of depression, right? So these are their risk factors. And then the AI engine from our particular solution standpoint, and hopefully for a best in breed solution, is going to recommend actions going forward to the care team, right? So it's not just identifying a problem. As you all know, as working in ACO, probably already knew that a third of the population was pre-diabetic. We know about the problem. So the real question is, so what? What are we going to do about it? And that's what the recommended actions come in for a good AI engine in prescriptive analytics. So recommendations are given, the care team can accept and modify, and then moving forward. So you have a precision medicine-like care plan for the individual patient that follows them through their whole care journey. In terms of intervention, so now we're kind of progressing from into virtual care technology. So we've identified the cohort, we know what their problem is. Now we have to actively engage the patient in order to change their behavior. So in looking at the art of the possible with virtual care technology, we talked about the remote patient monitoring devices, so connecting the glucometer to monitor the blood sugar readings. You can have educational prompts, right? So we said the solution should be circular. The care team is reading if they're seeing a need for educational push for something on diet or perhaps exercise, right? That can be done. And then very importantly also is the patient dashboard. So when you talk about patient engagement and how do you maintain patient engagement, it's really about giving the patient actionable, valuable information to them. And if we do that via the dashboard in a device, in their mobile phone device, in an app, which are 97% penetrated in the United States, according to Pew, then you're really giving yourself a good chance to keep the patient engaged and change their behavior. And then continuation with some functionality within virtual care technologies. You've got the secure bi-directional messaging, right? This is kind of in the telehealth component. So you might have text, you could have secure email, it could be a telehealth phone call that the provider schedules because they don't like trending that they're seeing with the patient. Digitized care plans for the patient in the middle app or the middle picture. So a lot of times what happens, patient goes in, they get discharged or they get papers from the doctor. Here's what you should be doing to take care of yourself. It's a stack of papers. They maybe read through it. It was 8 weeks ago. They haven't gone back to it since. They might not have understood some of the medical technology, the technical wording, and they just really never do anything with it. So when you have an app and it's easily accessible, and the designers of the app create a GUI so that the patient can understand and engage with the information, it's going to really improve your ability to stay engaged with the patient. And then lastly, again, back to the educational resources, that can include a variety of information, whether it's, again, going back to the importance of diet, pushing diet information to the patient, whether it's the importance of exercise. For example, one of the stats that really surprised me when I was studying prediabetes is that if a patient exercises just 150 minutes per week, with exercise being the equivalent of a brisk walk, they have a 71% chance of not progressing from being pre-diabetic to diabetic. So, it doesn't take a ton to really be able to impact the health of someone. And that's why that educational push is so important. We can do that with interactive videos. And then you can see local pharmacies, so we can connect them with local pharmacies so that medication adherence is easier to comply with. And last but not least, from an intervention perspective, it's your view, the provider view, right? So best in breed solutions are going to have dashboards so that depending on who's looking at the information, they can choose to digest it how they want. So it could be a director of pop health that wants to stay real cohort macro level, or maybe the case manager that wants to drill down to the micro level. They want to look at the 20 patients that they'd like to touch today from a priority standpoint, where those priorities can be sorted on based upon how the case manager wants to work for the day. So this information also then obviously should be able to be integrated with the EHR, so the provider, either provider has the flexibility to work either in the external application to the EHR or your EHR, depending on how user-friendly it is for applications like this. So that said, Rob, I think with the next slide, I'm going to hand it back to you to talk about the circular nature.
Awesome. Thanks, Kevin. Yeah, so just to recap, what you heard was how to structure a program for yourself, identify, use the AI to really truly identify the patient population that's at risk, assess that population to their specific individual and surroundings to better understand the why, and then obviously intervene with the right recommendations. This could be obviously individualized based on the specific data points, just to maximize the success and the impact to the program, and just truly personalize it. Ultimately track that success in the program, because if you can't measure it, you can't improve it. So you'll see that this is a circle, and that's why we see this as a circle, because you need to do this as a continuous monitoring, assessing the population, and any best of breed AI RPM programs out there will have to be dynamic. Use the AI continually to utilize the evaluate the population, so the patients could be added as they see fit, or more importantly, as a patient minimizes their risk potential for their type 2, they can be removed from the program, and maybe not as a monitoring, but just as an educational side point. Got to have the engagement. So not only from an improvement of the patient's overall health, this can have a huge positive impact to the bottom line. So I'll show you an example here of a really conservative ROI. This ROI is based on a pre-diabetic population of just 690,000. And again, we're utilizing the ADA stats throughout this. So if we even just say the progression rate of 11% of that population set of 690, that means an annual progression of type 2 diabetes is going to be just under 76,000 individuals. That 76,000 individuals, if nothing is done, that can really have a major impact, a negative impact to the institutions, coming to a total of $1.2 billion to the system. And that's only in 1 year. I mean, it's crazy to even try to wrap your mind around that. Again, these are all based on the ADA statistics of the annual cost of diabetes of $16,752. So let's say we could specifically identify that risk population and really focus on them. So in this example, again, we're using very conservative numbers and these things obviously can be changed to fit your specific market population or your beliefs, but we said only 15% of that population that we identified is going to join in this program. So an adoption rate of 15%. So now that 76,000 individuals goes to a little over 11,000 individuals are saying that they're going to be part of this AI RPM program. If we don't do anything to those individuals, it's going to obviously have an impact to the bottom line. But let's say of that 15%, we are able to affect 10% of those and prevent them from going to type 2 diabetes. What you're going to see here is now instead of 11,000, we're only keeping 1,100 individuals from progressing to type 2 diabetes. That can have a major impact to your savings in a version of about $19 million right to the bottom line to prevent those costs on there. I know you're saying it probably sounds too good to be true, but it is. Numbers don't lie. The key in this is that we find is targeting the right patients with that AI and having that active engagement platform, connecting the patients to their care team seamlessly without adding additional resources from your back end. Use the technology to its fullest. because the technology is here and it can definitely help you dramatically. But that's only part of the story. The other part is you notice at the bottom, there are CPT codes that can also apply to your remote patient monitoring and virtual care program. So what we said is, again, the adoption rate of only 15%, we're basing this on the population of 11,000 individuals. And what you can see is we're looking at the very conservative billing, but that could add an additional $26 million to the bottom line. So now you add them both together, 19 and the 26, the overall projected gross benefit could be well over almost $46 million. Again, just amazing numbers for a relatively simple move of the needle from 15 and 10%. So we're going to show you another example here of a large payer we're working on helping. Their pre-diabetic population is about a little over 866,000. And the way they're looking at this is if they're able to prevent that 11%, the ADA stats, and only looking at it from a direct cost, this can have a major savings to their bottom line. I mean, we're looking at almost $1 billion, 915 million. Now, they recognize that they're probably not going to be able to maybe prevent all 11%, but even with a fraction of the population they can help, it's going to have a major impact. Again, numbers just don't lie. So how do you define success on a program like this? There's a variety of ways. There we go. There's a variety of ways to define success in a program like this. And it all depends on what disease state, what you're trying to accomplish. But we put some examples here together. So what we see is we see a lot of people want to avoid the admissions, readmissions, reduction of ED visits, overall improvement of the patient's outcomes and health. I mean, we've been discussing diabetes only, but there's a very strong AI RPM model that can be beneficial to a variety of programs. And you can see those on the right, like behavioral health or other chronic diseases, COPD, chronic lung disease. I mean, there's a variety of ways that you can really help them on that. So in summary, you can make a huge difference in your patient population by utilizing artificial intelligence to gain insights, identifying the true at-risk patients, discovering their unique identifiers of the risk, and aligning the right messaging and care on an individual basis based on true data, not just kind of doing a swag. In addition, the remote patient management side and virtual care really digitally tethers your patients to your care team or your care system. It closes those gaps of care, reduces the readmissions and unnecessary ED visits, providing a lot of savings from a cost perspective as well as a resource utilization. And then probably the best thing is it provides us better care immediately. It's proactively engaging the patients to be a part of the solution, not just being a spectator, for lack of a better sense. With that, on behalf of the Mozzaz Corporation, we'd like to thank you again for your time, your interest in learning more. We're going to open this up for some questions you might have at this time, but you can feel free to reach out to Kevin, myself, or even to the generic email that you see right there at info@mozzaz.com. But thank you again. We're going to bring Keely in to assist with some questions right now.
Awesome. Thanks so much, Rob. So as he has mentioned, we're going to move into a Q&A portion of the webinar now. So if you have any questions, feel free to go ahead and put those in the questions box of your control panel, and we will get through as many of those as possible. If we do not get to your question today, either Rob, Kevin, or myself will follow up with you directly to discuss that further. Additionally, if you don't have any questions, we would love to kind of hear from you guys what your organization is targeting. Obviously, we've talked about diabetes today, but what other diseases are top of mind for you guys? So if you don't have any questions, we'd love to hear from you on that as well. So I'll give it a minute, and looks like we actually have some in the question box already, so we'll get started. The first one, how would you start to roll out a program like this?
Yep, great question. What we typically say is walk before you run. Since this is relatively new, utilizing AI, and when you're looking at some of these large numbers, it can be very daunting. So what we usually do is start with AI to maybe target a certain region, a certain disease state, and then roll it out in phases. As you start seeing the success and the impact on your patient population, we continually grow. But I would always start with walk before you run, with a very targeted and a very specific goal in mind.
Yeah, I would agree with that, Rob. I would add, from a more technical standpoint, we're going to, risk stratify, get to a number. Perhaps the provider group says we want to start with 500. We're going to identify the cohort, and then we're going to reach out to that cohort via text is most effective, email, try to drive them in to see their PCP, with their PCP understanding that a pre-diabetic solution has been targeted. They're going to understand the remote patient monitoring and virtual care as a part of the solution, prescribe it to the patient, and then we begin the process of changing their behavior to improve their health.
Awesome, thank you. So next question, going back to the ROI model that you guys showed, what were the assumptions you were making with those numbers?
Yep. So when I said it's a very conservative ROI, it is because the only assumptions we made were basically on two different factors: the adoption rate and the amount that was influenced. And those are the 15 and 10% respectively. Everything else we are basing off statistics on studies and information that was provided through the ADA. So what I mean by that is your costs might be a little higher for diabetes patients. The ADA took it from a national perspective, but based in your specific regions, they might be more. We could adjust those accordingly. But the only thing that we really focused on from a variable perspective is the adoption rate, which again was very conservative, as well as the influence, which ones we can prevent from going to type 2.
I don't really have too much to add to that, Rob, although I'll go back to the original statistic that I talked about when you're talking about the aversion rate, or the stopping a patient from converting from type 2 to being pre-diabetic, is simply if we can get them to exercise 150 minutes a week, you have a 71% chance to stop them from the aversion to type 2 diabetes. So if you pair that with the other virtual care technologies, the remote patient monitoring, the education push, I mean, it seems to me that 10% aversion rate is very conservative, and that the numbers can be much more attractive than that.
And just that, I want to add one more thing to that, if you don't mind, is the 150 minutes a week. By doing the proactive remote patient monitoring, you'll be able to see that. And you can tie a lot of different devices in with remote patient monitoring, whether it's a Fitbit or Apple Watch, or even just any device for that most part. What you find is, if you have a proactive engagement system in play and you notice that Rob hasn't been walking for 2 weeks, you can have the system use intelligence to notify him, hey, you look like you haven't been walking. Can you start walking? Before even a person gets engaged, to reach out to me, or to say, you got to start doing this again.
Yep, and I'm going to have to tag on that too. That's a great point, Rob. So with the remote patient monitoring, you all know that it creates an enormous amount of data, right? So the data in a smart system can be such that you have clinical triggers that red flag the care team when they see Rob hasn't been exercising, or his patient assessment form says he's depressed, he's not been eating well, right? So the AI and the platform can help make the care team more effective in when they need to proactively reach out to the patient.
Great. Next question. Do you take into account what might motivate each patient? Basically, is the engagement patient specific?
Engagement specific. I'll take a crack at this. I'm not sure if I understand the question, but one of the things that we say for a successful program is it's got to be personalized, individualized. And the reason I say that is I might prefer text messages versus email. Kevin might want not an app, but a appless type solution. So what I would recommend is know your population and offer them variety in there to be able to go, whether it's an email, a text, whether it's an app or an appless type solution, to be able to do the collection of the data as well as the interaction with them.
Yeah, I don't have much to add to that, Rob. I would say, meet the patient where they are. We know that patient preferences can be drawn really precisely down demographic lines. A couple of years ago, I was working with a call center that was servicing Cleveland Clinic, and they found that texting patients in a certain demographic was like 80% more effective than making phone calls. So not only were they reducing their costs from a call center perspective, but they're actually reaching patients with important information.
Great. And a similar question, so we'll go ahead and piggyback on that one. What best practices have you found to increase diabetic patient engagement?
Yeah, engagement's the key. I mean, you got to make it easy for them to get information, send information, and utilize information. So what we do is, I'll talk from our experience. So kind of going back to meet where the patient is. So from a patient engagement perspective, what we do is we utilize devices with cellular capability. So they are not having to work and type in any information to be able to be sent in from the RPM. We try to make it seamless. That's how we do it. And the reason being is it's one less thing where there could be a possible error where I might invert numbers by accident or type in the wrong number or forget to do it. Versus if I step on the scale, that weight is automatically going to be sent into my care team to let them know there's data being in.
Yeah, and it's not just diabetes patients. I think patients in general. So I think Rob's answer is right on the money. It's really meeting the patient where they are and making that engagement easy. We know, we're focused on the mobile app, and we know that according to Pew Research, the smartphone is 97% penetrated into the United States population. And so you can reach a really large percentage of a demographic with a smartphone and giving them actionable information that's valuable to them and it can help change their behavior, improve their health.
And you queued up another question here in the chat perfectly, Kevin, about changed behavior. So does your AI tell which patients can be influenced and which ones would be more difficult to change behavior?
So you queued that one up, Kevin. I'm going to give it to you.
Yeah, that's a great question, and the answer is yes. And if you remember the slide when Rob was referring to the circular nature of the solution, right? So the AI engine isn't done just after the initial cohort stratification. It's going to continue to comb through the data on an annual or on a daily basis, quarterly basis, monthly basis, because that 11% population that converts on an annual basis, they don't all convert on January 1. So the AI engine and the intelligence built into it is going to continuously look at the patient and make recommendations to make the care team smarter and give them a much better chance to change the behavior of the patient.
Great. So next question, activation and engagement can be challenging with technologies like the app that we've shown in patient portals. How do you deal with that?
You're quiet, Rob.
I didn't know if you wanted to take it. You're on a roll.
Yeah, so, we as healthcare professionals, we all know that the patient portals have been marginally successful. The last stat I saw said it was like less than 40% adoption rate. I've seen that number in a lot of different ranges, and I think it depends on how active the providers are in pushing the patient portal to their population. But I'm going to go back to the Pew stat and the convenience of using an app and why apps are more widely adopted in general in our population versus going to a patient portal where you have to remember the URL, you have to remember your username and password, and then you're going to go in and read very clinical information that you may or may not understand versus the app on your phone that you click on, and it's been designed by designers that specialize in making GUIs easy to understand by the patient, not only from a use perspective, but kind of dumbing down the information from a clinical perspective so that the average person can understand it.
Told you you're on a roll.
Great. So with that, we're going to go ahead and wrap up the brief Q&A period, and I'm going to pass it back over to Garrett to get us all wrapped up. As a reminder, if any questions come up after the webinar, feel free to reach out to us at info@mozzaz.com. But with that, I'm going to pass it back to Garrett.
Great. Yeah, thank you all, and good job, Keely, with the Q&A. If I can have you advance to the next slide, Keely, I wanted to, as we wrap up here, to encourage you all to visit the Mozzaz exhibit booth at acoexhibithall.com. And this is where you can learn more about them, watch some videos, connect with their team. It's a really great way to get more familiar with what they're doing. And also at acoexhibithall.com is where you will be able to find the recording of today's webinar. So we have a library there that you can search, and all the webinars are there. And so this webinar will be there as well. But I will also be sending it to you via email afterwards. So with that in mind, I would like to thank you all for attending. Keely, if you could go to the last page, this is where you can see their information is posted here. If you'd like to get in touch with either of our speakers or the Mozzaz team, feel free to reach out to them here. Thank you all so much for coming. I know there's a lot of distractions right now, a lot of stuff vying for your attention. So really appreciate you being with us, and hope you have a wonderful rest of your days. Thank you so much.